Hello, good morning. Yes, I'm good. So, welcome to day two. Now, today we have got lots of ground to cover, right? So, we'll be going bit fast. But say for tomorrow, I'm planning a small exam. Now, that would be a very honest exam. Say, I'll keep on presenting you the question, and it would be written like, say, option one, two, three, four, right? And in some cases, I won't write the options. You have to simply write the answer in your notebook. And then finally, after say 20 questions, we'll discuss all the answers, right? So that way you'll be evaluating yourself, but it would be like a good practice. But that's what I said. It would be an honest exam. All right. Okay. So let's start with our today's topic. Now say, as I said that today we'll be covering lots of grounds. So first we'll clear our complete concepts on ANS, including all the gray rami communicants, white rami communicants, that way. So that picture is completely clear that where exactly the nerves are going, where exactly are the ganglia, what are about the lateral horns, what about anterior and posterior horns, everything. Once it is cleared, then we'll be taking some other topics. It is like that injury, what happens when the nerve is injured, right? Because those topics, they carry a very specific meaning even in your exam, even in your day-to-day life. So we'll take that. And tomorrow we'll be actually going into those details where things are pretty complex. So as such, tomorrow's topic would be like where we'll be going into in depth about all the chemical changes, etc. But well, unless and until we don't know where exactly it is happening, it becomes quite confusing. So today's purpose would be knowing precisely what we are talking about, because tomorrow we'll be talking about straight away alpha 1, alpha 2, alpha 3, or the beta, right, or muscarinic or nicotinic receptors. That way straight away we'll be talking about that, with some exceptions, with some few of the receptors which are not present in human beings and they are present in even other, say, animals, right? So what are the meaning of that? So all those chemical things, that is, in other words, those who already know that thing, what I'm talking about is G protein coupled receptors, and what are their formation, what are those GQ, GI, right? All those things we'll be taking tomorrow, right? But so let's start with our ANS, autonomic nervous system. Some things will pick up fast, involuntary, right? Controlling smooth muscles, glands, and heart, that is myocardium, except neuromuscular junction of striated muscles because they are obviously voluntary, right? So they are voluntary, they are under your control. Now, when we talk about autonomic nervous system, sympathetic, parasympathetic, that is fight, fright, and flight, right? Fight, fright, and flight. We talked about it yesterday. Say, because this is sympathetic is something which is sympathizing us when we are in stress. Correct? So basically, it is like an alert system. It is telling that yes, you are in danger, so take care of it. And we'll see some clinical aspect of it also. In case of parasympathetic, we say that simply rest and digest. And then there is something like second brain. Yeah, second brain. It is actually called as second brain. But like brain, it won't be going for all those higher level of intelligent and higher level of intellectual functions. But still, this ENS is worth understanding, right? It is what is called as the enteric nervous system. So let's finish that thing. So it will clarify many of the concepts at the same time in anatomy. When you will be learning the abdomen and pelvis, right? It will make a big sense. Okay? So this ENS is the intrinsic nervous system of GIT. Well, we said that in GIT, it has got smooth muscles. Yes, it has got smooth muscles, right? All those smooth muscles, they are getting supply from sympathetic, parasympathetic. Everything is happening. True, very true. We said that there are sympathetic ganglia. Yes. There are celiac and supramesenteric and inframesenteric ganglia. Very true. There was sympathetic chain and they were supplying all of them. Then from where this thing came, this ENS, right? From where it came. In order to understand this thing, say, if you see, there is something, there was a serial called Star Trek, right? Captain Kirk was there, right? And its opening statement itself is these are the voyagers of Starship Enterprise, those who are seeking to the deep space where no man has gone before. When the starship it goes, now this is like fiction, but in reality also Voyager, right? Our Voyager from NASA, it went into deep space. Its purpose was to cross our solar system, that is Mercury, Venus, Earth, Mars, Jupiter, Saturn, Uranus, Neptune, Pluto, all the way, cross everyone and then go into the deep space. Now, when it goes into the deep space, these are the electromagnetic waves. They travel at the speed of 3 lakh kilometers or 1,86,000 miles per second, right? So 3 kilometers, 3 kilometers, 3 lakh kilometers, 3 lakh kilometers. It is at that pace it goes. But the distances are so high that, let's say this Voyager it is traveling at the speed of 80,000 kilometers per hour. Well, that is true. 80,000 kilometers per hour, and it is not very high. This is just kilometers per hour. We talked about light, right? We talked about light. Light when it is passing at the speed of 3 lakh kilometers per second. So with that pace, right, when the distances are high, they have to take their own decision. This is where there was development of intrinsic automation and controls. Now, when it comes to a human body, say ENS is exactly like that. It is intrinsic nervous system of GIT because GIT is handling so much. So GIT said that it's okay, I'll be taking inputs from the central nervous system. But otherwise, for small things, I'll handle the things by myself, right? So over here, these are what is called as the reflex local circuits. These are the reflex local circuits. So input is in the form of what? Input is in the form of physiological conditions of GIT. Whether there is any dilatation, whether there is any stretch, right? Direct input is from the condition of GIT. And as soon as it is perceived, there are nucleus also in this. The output goes into the form of, say, it controls gut movement, any of the fluid exchange is needed, whether we need to increase or decrease the blood flow, all those things, they are like local autonomous function. Now, because this is local, right, the GIT is so long. So wherever things are happening on those spots, these local systems, they'll keep on working. And that's the reason that it is also called as the second brain, right? It is also known as AKA, also known as the second brain. But there is a two-way communication between CNS and ENS. They both keep on constantly updating each other, right? How sophisticated the entire system is. Now in ENS, we should not underestimate it. It has got more than 20 types of enteric neurons. And these 20 types, they are by their function. The total number of neurons, if you talk about, it is in millions. And it is not 1, 5, 10 millions. It is like 100 million, right? So many, so many. But there are, if you divide how many types are there, so they are like more than 20 types, right? Okay. Let's divide it into very simple classification. One classification is that class 1 and class 3. Class 1, they are sensory. Class 3, they are motor, right? Because this is completely intrinsic system. It is handling things by itself. So that's why it has sensory and motor things both into its own system. And then there are few interneurons, right? Those who are interconnecting. So we have intrinsic sensory neuron, intrinsic motor neuron, and then there are interneurons, connectivity between these neurons. And what are they? They are like enteric neuron, myenteric plexus. Plexus means group, right? Group of nerves. So these are plexus. Myenteric plexus, submucosal plexus. So at histological level, when we see that, okay, these are all those plexuses, right? Few of the collections of those nerves, but actually they are complete word in itself, right? And as I said, we are dealing with not less. It is like 200 to 600 million neurons, those who are into GIT and they are handling things so effectively. Right? Now, when it comes to brain, right? So this is hypothalamus. And in hypothalamus, there are two parts, right? Anterior part and the posterior part. So this anterior part, which is parasympathetic, and the posterior part, it is sympathetic. But this hypothalamus is getting the feeds from all the other organs, all the other areas, right? Say for example, we talked about occipital lobe. So occipital lobe is for vision, right? Is for vision. So it means if there is someone with a gun in front of you, so that means it is a major emergency, right? You need to protect yourself. But what if it is a toy gun? Well, it's a toy gun that you know only if your memory is telling that no, this type of gun, this is a plastic gun, right? It has got no effect and this is safe. So that feed you get from your memory because of your past experience, right? Otherwise, it is equally threatening. Then there is temporal lobe. In temporal lobe, there was so much, right? Right from the hearing to converting into permanent protein, permanent, that is short term to long term memory, and the language and the facial recognition. And frontal lobe was taking those fine decision, and placenta, this parietal lobe was placing us properly into the position that is the 3D position. So that's what it processes, our position, right? So that's how we remembered everything. All these things, they are fed into the limbic system, which is for our emotions, right? That's the reason that if anything is associated with emotions, we always remember it. Now all these feeds, they will go live to hypothalamus. Now this hypothalamus reacts. Hypothalamus will say, okay, this is nice, soothing, comfortable system. Fine, go for parasympathetic activity. If it is like sympathetic activity, when things are like high alert. So basically, in your everyday, day-to-day life, it is the parasympathetic which is working day to day, right? Unless there is some critical situation. In that case, sympathetic kicks in. Now, after some time, we'll see that what sympathetic will do to blood pressure. Sympathetic will increase. Yeah, that's right. Sympathetic would increase blood pressure, right? It would increase blood pressure. Now, though so many things are there, but I'm taking just one simple example that it increases blood pressure. Why should it increase blood pressure? Because it will say that whenever there is stress, right, we need more oxygen, we need more blood supply. But someone would say, where is the stress? Person would say, what if say in equity market, the price of that share which I purchased, what if it goes down? Well, if it goes down, and then if your blood pressure rises, is this going to increase? No. But yes, it happens. What I am telling you is, as talked yesterday, the altered state, right? The book which I was reading, the altered state, that described this thing so effectively that yes, people are going for the shortcuts, right? Taking all those drugs and so many other things. But actually, someone asked also yesterday that meditation, yes, it is helpful. It's so good, right? It is so good. And in all the four states, that is alpha, beta, delta, and gamma state, so you can transform yourself from one state to another. So it's like when you are studying, actually, you are into that state. In that state, it automatically enhances your creativity, your focus, and the best part is that it is your own world. When you are into that world, any of the distractions, they won't touch you. That was the best part of it. So what happened is, because I read and someone suggested me today only that if not more, you can take a separate session on it for say 15 minutes, half an hour, like that. And then someone gave me the idea that the books which you read, why don't you come up with say summary of those books, so just for 10-15 minutes, but that would be much better. And well, it was a good idea. I'm thinking about it, right? I'll work on it. But yes, this thing to appealed me so much, the altered state. And actually, it's not so that you have to practice that for say 1 year, 2 year, 5 years, 10 years, and then suddenly you start getting those feels and vibes. No, it is like it is instant. It is instant. It's a matter of just 15 to 20 minutes. And you do it, it is exactly like that. How much time you really spent for cycling, right? How much time you spent for cycling, say learning the cycle. It was like you'll say that I learned on the third day. But that doesn't mean you were practicing for 72 hours. Actually, on the first day, you went for that practice for say 15 minutes, half an hour, 1 hour, right? And then you fell, you might got some bruises on your knees. Then once again, brave heart, you went on the second day, you practiced, and suddenly on the third day, you started learning. Actually, you learn swimming or cycling. Both these things, they are absolute body balance. Actually, you learn within 4 hours. Because even in swimming pool where they give training, right, the training session is of only 30 minutes. And on the fourth or fifth day, the people are swimming so effectively. Then it comes to practice where you increase your endurance, right? Same thing is over here. Same thing is over here. So, right? So this blood pressure, that's why it came in my mind, because people raise their and stimulate their sympathetic nervous system without any alert. So the day there is actually an alert, right, this system goes haywire because you have shifted your baseline to a very high level. So from there it goes high. That's where the blood pressures, they keep on rising even under normal circumstances or situation. Now let's talk about sympathetic first, then we'll move on to parasympathetic. This is thoracolumbar, right? That's what we said. T1 to L2. Now these are the terms. Now we know what is preganglionic neuron, right? Preganglionic neuron. What is sympathetic ganglia? What is sympathetic chain? What is postganglionic neuron? And what are prevertebral ganglia in the form of celiac, superior mesentery, and inferior mesentery. Right? This much we talked about in depth yesterday. One important thing, that none of the cranial nerve coming out has got any sympathetic outflow. None of the cranial nerves, right? All those 12 pairs, right? They say that we don't want even to talk about sympathetic system, right? They won't talk about it. Even in case of, say, parasympathetic, there are only 4 nerves which will be dealing with it. Otherwise, rest of the nerves, they are purely somatic, right? One another point. Now, I'll take it in the diagram, right? Just remember this. First, I'll just explain that from the spine, when that fiber comes out, which is a preganglionic fiber, right? Now, actually, it should go and land into the ganglia, sympathetic ganglia, but it bypasses. Yes, it bypasses and it might reach to prevertebral ganglia, right? And in prevertebral ganglia, it might go into celiac, might go into supramesenteric, or might go into the inferior mesenteric. But few of the fibers, they reach to the adrenal gland. And in adrenal medulla, they reach. So it means they go all the way to adrenal medulla, stimulated, and this medulla will be secreting the chemical which will be circulating into the entire body. So over here, we are dealing with two things. One, that those postganglionic fibers, right, when they secrete the neurotransmitter which will be stimulating specific receptors, and the action would be taken. What that action? Now that action could be, say, tell the GIT to stop, tell the heart to improve the speed, improve the conduction, and improve the force, right? So that is what is told to receptor, but it is in between, it is the neurotransmitter. So this is one neurotransmitter which is released locally, and then adrenal medulla is releasing another chemical which is going all the way into the circulation, and it is affecting everyone, right? So we'll talk about this. 3, 7, 9, 10. 3, 7, 9, and 10. These are the cranial nerves. These are the cranial nerves. They do have parasympathetic component. So first, let's understand this figure. Okay. Yes. We'll come to that. Okay. So here is our cross section of spine. That's anterior, right? And we'll start with the gray matter. In gray matter, yesterday we said that gray matter is where there are cell bodies, correct? In brain, they are onto the outer side. So when this is the situation, in spine, it changes. So gray matter is inside and white matter is surrounding it. True. But still, that's very true that wherever there is gray matter, there are cell bodies. Okay. And wherever there is white matter, so white matter means these are the tracks. So over here, this is the portion of input output, and that central portion, that is where the gray matter, where there are cell bodies, right? There are the cell bodies, and they will be the processing component. So we have 3 horns, right? Let's mark ventral horn, the lateral horn, and the dorsal horn, right? And the dorsal horn. So these are the 3 horns. These are the 3 horns inside the spinal cord. But the output is in the form of only 2. And these are the motor neurons, or what we can really say, that we have got just the ventral root and the dorsal root. I think this is better, right? We have got just 2 output, that is the dorsal root which is coming, and then there is a ventral root which is coming. At this point of time, we are not thinking that what is the content of the dorsal root and ventral root. Okay, So we have to handle three things. This dorsal root, this dorsal root is sensory. Dorsal root is sensory. This ventral root is motor, right? Ventral root is motor. And then we have to handle the sympathetic component, right? That is also handled by this lateral horn. So let's combine all of them in this way that this sensory neurons, they will be coming, right? These are the sensory neurons. So here are they, right? This one we are talking about. Correct. So they reach. So that's what is called a sensory neuron or the general somatic afferent. They are just coming, right? They are coming and they are sensory. And in response to that, there is motor neuron, right? So that's the motor neuron which is going out. Both of them finally they'll meet and then they will go in the form of this what is called as the spinal nerve. Spinal nerve. So it is the spinal nerve in which there is combination. There are some sensory components, there are some motor components, and then they reach to respective organs. So far so good. But then we need to control even the automaticity of all those organs, right? By this ANS. So the fibers of this sympathetic system here is where they start and then they go into this ventral root for some time. The moment they see that array there is my ganglia, right, immediately they'll jump out. Those fibers, they will come out, they will leave this root and they will reach to that ganglia. Then those fibers, they take the decision whether they are supposed to go up, go down, bypass or terminate over here, or bypass and go to adrenal medulla. 5 outcomes, right? Either they go up, they go down, they terminate, right? Or they bypass and they go to adrenal medulla, they bypass and then they go to that prevertebral ganglia. So let's say for time being right now, this is a very decent fiber and he said, yes, I'll get terminated over here. So this portion, what I drew, this is what is called as the white rami communicants. And it has to be myelinated because that's why it is white, right? Okay. So there is a ganglia. Now, then there are post-ganglionic fibers. Those fibers, they'll say, chalo, let's start our journey. So they'll start their journey and they will come out, but there is no special sympathetic nerve given to them that, okay, you go by this. They'll say it is this bus of spinal nerve is going, you also ride into that. So they'll send their fibers and they'll ride themselves into the bus of spinal nerve. Now spinal nerve is carrying these fibers. So this journey from ganglia to spinal nerve, this is non-myelinated. This is non-myelinated because they'll say you won't need a super fast vehicle, right? This is a short distance, so you just travel and reach over there, and from there it would be taken care by the spinal nerve. So this entire bundle is a spinal nerve. That's how it goes. That's the reason in anatomy when you say that, okay, these are the nerves, but yeah, sure, that when it is said that these are the nerves and they will be supplying these organs, and then suddenly there would be like, it also gives sympathetic innervation to respective organs. It gives sympathetic innervation to, let's say, bladder. So then we feel that why there are so many different types of supplies of the bladder, right? Then there are specific muscles, specific supply for detrusor muscles, specific supply for those say sphincters. The final output is very fine. It is the final output what it really matters, that it is of concern. Okay, coming back to this white remi communicants, say yesterday we saw that that's the axon, right? There was cell body, and then it is, if it is myelinated, so this myelin, it is covering this axon like a sheath. So this myelin sheath, it increases the conduction speed. How it actually increases the conduction speed? It is like these are the node of Ranvier. So every node, it will allow the jumping of the pulse. So they don't have to actually repolarize, depolarize, repolarize, depolarize. Actually, those junctions, they are immediately skipped, right? Immediately from here to here, pulse would reach here, here to here, it would reach. And then, because wherever these myelin sheaths are not there, there the entire this polarization, depolarization, right, that will keep on occurring. So these myelin, presence of myelin, it gives white color, right? So that's why white rami communicants, right, white branches which are communicating, that's the actual meaning of it. So it is myelinated, right? It has got the myelin. So that is white rami. Rami means branches, communicants means they are communicating, they are talking. Okay, so that's the white and the gray rami communicants. Okay, let's understand one more interesting principle. Parasympathetic is in our day-to-day life, right? Parasympathetic is in day-to-day life. So when it comes to day-to-day life, things are very specific. Things are very specific. And when it comes to sympathetic, it is like an high alert system. And when there is an high alert system, let's say if there is fire, so then without any discretion, straight away you'll start extinguishing the fire wherever is possible, right? There is no method. You will simply attack on that fire. Same thing. Whenever the sympathetic system is acting, it is acting on a large scale, right? It's not so. It will never ever happen that, okay, head has gone into sympathetic activity, however, rest of the body is still into parasympathetic activity, right? Only the blood pressure of right arm is increased. No, that won't happen. If it rises, everything together. When it goes down, everything together, right? So it acts as a one system. When it acts as a one system, it means there has to be a wide base of action, right? There has to be a wide base of action. And this action depends upon the postganglionic fiber. So postganglionic fiber, when the ganglion tells you, okay, go and extinguish that fire, right? Go and neutralize this situation. So that's where it is like fight. So when there is fight, you don't do it like that, yes, I'll fight with only my right hand because my left hand is right now into parasympathetic, so is relaxed. No, it is the entire body is into action, right? So that's why it is going on, it has got the wide base. So see this part, that as we said that it is the thoracolumbar, right? So it is this thoracolumbar region we are talking about. This thoracolumbar region is sympathetic. When it is sympathetic, right, till preganglionic, they are short. But then those postganglionic fibers, they are long fibers, right? Giving so many different connections. So this postganglionic, they are long in case of sympathetic, right? Even those going to the sweat glands, right? They are also all postganglionic, they are all long. Okay. When it comes to parasympathetic, it is just the other way around. Parasympathetic, they have got the short postganglionic fibers because their function is like specific. So for specificity, right, you can say for specificity, it is having short postganglionic fiber, and for versatility, sympathetic has got long postganglionic fibers. Fine. The next thing about the neurotransmitters, whether it is sympathetic or it is parasympathetic, we are now talking about only two connections. That's our ganglia. That's our ganglia. Whether it is sympathetic or it is parasympathetic, we are talking about only acetylcholine. Only acetylcholine. Right? That difference, whether you are sympathetic or parasympathetic, that depends upon the final action. Otherwise, during the entire journey, to everyone is same, right? So it is acetylcholine which is working on into that ganglia. Now the postganglionic fibers, they are coming out, right? They come out, and let's talk about, say, this portion, that is thoracolumbar portion, that is the sympathetic. When they reach to the organs where they are supposed to act, it is at that point they'll say, okay, we are sympathetic, so let's deal with now norepinephrine. Right? There is adrenaline and noradrenaline, right? Adrenaline, which is releasing from that adrenal medulla, right? So adrenal cortex or the adrenal gland, right, which is having cortex and medulla. So this adrenal gland itself, it is called as an endocrine gland because it pours its secretion straight away into the bloodstream. And then that blood which is spreading into the entire body, right? So it goes and entire body is on fire. Meantime, these nerves are also firing, right? So they'll release norepinephrine. So the norepinephrine is a neurotransmitter, right? It is a neurotransmitter. And while this adrenal secretions, they are the, right? They are like chemicals. So these chemicals which are released into the blood and they reach to the entire body, the effect, it remains the same. So it is the norepinephrine or epinephrine, right? From where they are coming. Norepinephrine is in the form of neurotransmitter secretion, epinephrine which is coming from adrenals, but their effect is the sympathetic effect. Okay. So that's what is happening in case of sympathetic. Now in case of parasympathetic would say that this is like day-to-day operation, right? And in day-to-day operation, why to make the things complex? By multiple neurotransmitter. So it'll say that whatever the neurotransmitter we have, बस उसमें से चला लेते हैं, right? तो it'll say that acetylcholine is in stock. तो ठीक है, right? Let the acetylcholine come even into our final destination also. So acetylcholine is working in case of preganglionic and the postganglionic also. So that is on the effector organ, right? These are called as the effector organ, where actually effect is taking. So there also it is the acetylcholine works. So simply that's how it goes, right? So here, that in case of parasympathetic, we got the long preganglionic but short postganglionic because we want a very focused effect. And in case of thoracolumbar, that is sympathetic, we have got the short preganglionic but then long postganglionic as we want the broad effect, right? So that's the difference. Parasympathetic is for homeostasis. This word will come quite frequently. Homeostasis. Homeostasis means balance, right? Homeostasis means stability. Your body requires stability. Your body requires homeostasis. So in case if things are very hot, right, there is high temperature, there is so much of heat, body will try to maintain that body temperature. The day it fails, that is what is called as thermoregulation failure. The day it fails, the day any of the system fails, it leads to so many complications. So when this stability or the homeostasis or what is constant, right, that thing, if it is affected, it's pathological. So there has to be some reason behind why it is happening. Unless and until you don't remove the cause, don't remove the reason, things would persist. Exactly the same way, if there is very high infection and that leads to fever, high grade fever, well, that's okay. You start giving loads of paracetamol, fever would come down. No problems. But for what duration? The moment that effect of the drug is gone, immediately infection would kick in, that fever again, right? So that's because body has not been brought to homeostasis, right? Some systems, they are on fire. So that's why sympathetic is day-to-day operations. Sympathetic, you can always say it is like an high alert system. That's the reason that when things are on high alert, entire body reacts to it. Okay. So what effects we see? So here is our heart, the most sensitive portion. Parasympathetic, right? It is like rest and digest. So then why do we really want to trouble our heart, right? So it decreases the heart rate and it decreases the force. Someone, right, way back, they said, sir, in that case, so one should never do the exercise, right? One should never do the exercise because when you do the exercise, heart rate increases, and yes, it increases massively, right? And it increases the force also. So why are we troubling our heart? And then there was one supporter also. He said that number of beats for our lifespan are fixed. So when we do exercise, right, we are consuming more number of heartbeats, so our life would decrease. Right? Well, their logic was not very wrong, except that when you do exercise, you know what happens? Yes, at that point of time, your heart rate would increase. But then there is something which is very important. It is called as the resting heart rate. Resting heart rate. That resting heart rate would come down. When the resting heart rate comes down, it means you are less prone for any of the infarction, any of the trouble to the heart. Because when the heart rate is at a lower level, that means there is so much scope of, say, improvement. There is so much scope of pumping more blood in case of any emergency, right? So as you will be running long distances, you'll find that your heart rate keeps on fluctuating between 150, 160, right? If it is going like this, but for such a long duration. So actually, this is the capability of horse, right? Horse has got this capability. He keeps on running on and on and on. That's why all our vehicle, they are measured in the form of horsepower. They don't tell it cheetah power. They don't tell it elephant power. No doubt, elephant, cheetah, lions, they all are so powerful. But it is always considered in the form of horsepower because it is like endurance and the speed both. Okay, so over here I just tell you about this. When we are dealing with rate of heart, that is at what rate it beats, that is 70, 80, 90, 100, it is called as the chronotropic. Chronotopic. This is easy to know. Chronology means in the sequence of time. What is coming first, what is coming second, right? Chronological order. So this is called as chronotropic. Chronotropic means associated with time. So is it positive chronotropic or negative chronotropic? Positive chronotropic means forget about the output. At what speed heart is beating? If it is at 72, right? And from 72 it goes to 100, so then it is positive chronotropic. Good. The second one, when we talk about the force, then that force is called as the ionotropic. Ionotropic. Till you'll go in pharmacology, these words will not be coming more into picture, but straight away over there it will say that this drug has got positive chronotropic and the ionotropic effect. Then there would be another drug which will say that it is having positive dronotropic effect. So dromotropic effect is when it increases the conduction speed, right? Where it increases the conduction speed. Now, how can these drugs, they increase the conduction speed? How are they over there increasing the force of the contraction? How is it, right? Or why are some of the medicine, they are increasing the heart rate? It is all because of, go back to those action potentials, right? It is like that those muscles, they are contracting because as it was going up, then there was initial repolarization, right? And then there was a plateau, that plateau which was occurring because of what was happening, because sodium activated, right, voltage activated sodium pumps, they have closed, and voltage activated potassium pumps have started. But it is at this point the calcium kicks in. That small amount of calcium, that calcium, when it comes inside, potassium is going outside, calcium comes inside, that small amount of calcium, it thrusts those endoplasmic reticulum, right? And that is what leads to CICR, right? You remember CICR, calcium induced calcium release. So that calcium which was coming, that was in small quantity, but it triggered that endoplasmic reticulum. It is like that you have opened that safe with that key, and when you open it, and then there was a rush of all that calcium, and that calcium which leads to the contraction. So what if you can make this process faster, or you can make this process longer, right? So it means the heart would be contracting with more power, right? It would be, say, also, you tell the potassium that yes, you are going out, that's okay, right? But by adjusting the speed of that potassium, you can again make changes into the contractility. So everything is revolving around that game only, that how it happens. Now let's say how the heart rate increases. We know this part, that slowly and gradually it is that sodium which was entering. It entered, and at one particular level, that was the threshold level, and immediately it shot, right? What if we reach to that destination fast, so that those voltage triggered systems, they act faster? But so that is how things are done. If you start putting it in such a way that those sodium channels, right, if they are working more actively, so that voltage activated sodium channels, they open, so this would lead to a faster cycle, right? So whether the cycle is to be made faster, whether you want to talk about only that contraction phase which is more powerful, so every game is revolving around that. In case of sympathetic, there is increased heart rate and increased force, so that is positive chronotropic and positive ionotropic effect. Regarding the lungs, right, don't try to cram that what is happening in lungs and what is happening in heart. Think about rest and digest, right? You have consumed, you have taken your heavy dinner, and now you started a movie. Now there is no trouble, right? You are not going for a marathon, or you are not going for a sprint. So then why do you need more oxygen? So why to trouble those bronchus for getting dilated, right? Tell them that, well, you can also relax, contract, right? Maybe of a smaller size, no problems, because less oxygen is needed. Less oxygen is needed. While if it is an emergency, yeah, in that case, so we need to tell that yes, we require more oxygen, so broaden the pathways, right? Open the doors, and then bronchodilation. Okay, here is I, right? we can always watch the movie like with half open, half closed eyes, right? We are relaxing. So let the pupils be constricted. In fact, when we constrict our pupils, right, we can see the things with much better clarity. Due to exercise, increase in heart rate is done by, yeah, it is obviously it is done by sympathetic system, because when you are running, right, your demand increases, so everything kicks in, that oxygen demand is more, so okay, fire, heart rate increased, force increased, but then your muscles, your myocytes, right, your myocardium, your cardiac muscles, then they are trained. You are training them so that for less oxygen also they will keep on working, because their efficiency has increased. That's the reason that first, second, third day you go for exercise, right, you go for exercise and there is lactic acid accumulation, but then later it goes away, right? Yeah, so that's it. So then once it is conditioned, so it is the parasympathetic which will take over, and your heart rate would be even less than the normal, right? It would drop then below 72. That is the athlete's heart rate, right? Yeah, see, as such, it is like a stress, simply because of one reason: your oxygen demand is high, right? Now, see, I tell you, uh, those who I think this is not a very good example, but there could not be any other example like this. Those who really kill themselves, right? Those who kill themselves, those who commit suicide. So in that case, they try to go for all sorts of combinations, right? Many times, say, this I remind because just before some time I saw one serial in NCIS. One of the sergeants, he killed himself, and there was a bag, plastic bag, which was wrapped around his head, and he tied his hands. Now, at that point, right, during the autopsy, the the condition of the heart was like, as if the heart which was shown, right, it was massive, as during high heart rate, and then the heart collapsed. Why the heart rate should go so high? Heart rate goes that high because, say, due to strangulation, this oxygen is now no more entering into the system. When it is not entering into the system, brain fires. Brain is not understanding that whether this lack of oxygen is due to some constriction, or is it because of some error in the system. It will say it is less, so simply go for the positive chronotropic effect, right? It is positive, right? From 70 to 100, it is the chronotropic effect, so it is increasing, heart rate is increasing. So over here, coming back to this I, so it is constricted in case of this, and when it is, say, sympathetic, it dilates as it would try to cover a larger vision. So what should be done? Same way, all those hairs, right? So these piloerection, that means all those hairs, they will be standing on their root, right? This is more seen in cases of porcupine, right? Porcupine, when it tries to attack, so at that point, as such, it is so small, and suddenly, right, it's all those spikes they raise on their tips. So that is what is piloerection. Here they relax. And the urinary bladder, it works in bit different way. Urinary bladder has got those detrusor muscles. Those detrusor muscles. These are the muscles. This is trigon. These are the detrusor muscles, right? And then there is sphincter. So it works in this way that when these detrusor muscles contract, right? So then the bladder is emptied. But if the situation is not right, so in that case, detrusor relaxes, right? And the sphincter contracts. Sphincter contracts. So that sphincter, which is a voluntary control, there are two sphincters in males, right? In female, there is one. But these sphincters, say the sphincter which is under voluntary control, that contracts, upper one also contracts, so that there is no way that urine can leak out. At the same time, because the bladder is extremely sensitive to those stretch receptors, right? We'll come to this, right? Say, so these detrusor muscles, right? These detrusor muscles, when they relax, they will increase the size of the bladder. Once the bladder size is increased, that means there would be less of there would be more possibility of collection of fluid, right? That is the urine. So thus, it is the bladder size which keeps on increasing. While when the person is relaxing, well, it's fine for him to empty his bladder, so it constricts the detrusor. So these are the things. Know some of these terms. One, whenever it comes to mimetics, right? Remember mime. It is like mimicking. It is like acting. So these are the drugs or the chemicals who will be acting like as if they are parasympathetic. So parasympathomimetic. Now these words will keep on coming, right? Parasympathomimetic, cholinergic, antagonist. So their meaning is that parasympathomimetic means they will be stimulating parasympathetic system. So that's why they are also called as cholinergic. They are cholinergic because acetylcholine is what it is in use. So those drugs, they are not acetylcholine, but they'll behave like as if they are acetylcholine. And if our receptors, they'll say that yes, I'll obey only acetylcholine, but then if someone comes with the mask of acetylcholine, yes, our receptors would start working. That is what is called as parasympathomimetic or cholinergic. These are the chemicals which are fitting exactly into those slots and they will behave as if they are acetylcholine, right? Okay, so they are parasympathomimetic. Then there is reverse parasympatholytic. It will break. It will say no. It is just the reverse of mimetic. So that is inhibitory of parasympathetic nervous system. In sympathomimetic, yeah, now it is same. Sympathomimetic, it will mimic sympathetic system and also called as adrenergic, right? Adrenergic. So these are the adrenergic as they are dealing with, say, adrenaline or noradrenaline, right? Also called as epinephrine and norepinephrine, right? We saw the difference of both. And then the sympatholytic, right? So sympatholytic is inhibition of sympathetic nervous system. So they are based on anatomy. Now based on transmitters, when we say cholinergic, so yes, it makes sense. Stimulates parasympathetic system. Anticholinergic, that is just the reverse way, right? It is the reverse of that. So it inhibits. Adrenergic, yes, that is sympathetic. Adrenergic, so it inhibits sympathetic, right? Okay. Now, adrenergic receptors. Till this point, we have not talked about receptors. We talked about the entire anatomy, how things start from brain all the way it comes to spinal cord, to preganglionic fibers, to ganglion, to postganglionic fibers, then white rami communicants, gray rami communicants, they go into spinal nerve, they supply everyone, fine. We have reached to the destination. Now the organs are there. What these organs would do? Now, if we say that it is so simple that these organs, right? These organs, sympathetic, so they should contract, and parasympathetic, right? They should dilate or they should relax. Okay. Why so? Yeah, well, it is the muscle power we have to fight, so those muscles should contract. But then immediately it comes that what about GIT, right? This GIT should not contract, because otherwise during that fight one has to visit washroom, right? It is GIT should relax. So now this is like a mixed situation, right? This is a mixture of situation. Some cases it is needed to relax. What if the respiratory systems, right? Those respiratory, they'll say, okay, bronchials, they contract. So that would be leading to bronchoconstriction. We are requiring more oxygen and bronchus, they are contracting because we said that sympathetic should contract. So it is not like that. It will say that the contraction would be needed in only specific areas, relaxation will be needed in specific areas, but how to handle it? Well, that's the game of receptor. That's the game of receptor, right? Again, it is exactly like those commando forces. In those, there are few snipers, right? Those snipers, they will take the target and then they will wait. They'll keep on waiting till the command comes and it is said that, okay, knock off. Otherwise, they'll keep waiting. They'll not take any action because they are safe. They are watching the situation. While there is another force, which is like rapid action force, they will immediately take action, right? As it comes. So you need to give different orders, right? Those rapid action force, they won't ask, okay, well, he has already fired, right? Now the bullet is on the way. Should I fire back? Right? No. So that's how things they go actually in our system also. Let's see that, because this entire game is of those receptors, right? What is already told to those receptors, what they can do, and where they are placed, right? Only three things you need to remember: their location, their function, that what will they do, right? What I mean to say is whether they stimulate or they inhibit. Right? Whether they stimulate or they inhibit. Receptor can do this only because the work is to be done by that organ, right? If something is stimulating to a gland, so then that receptor won't say, okay, you take rest, I'll secrete those secretions. No, receptor would say, say, the command has come, you are supposed to do your work. Gland, secrete. So gland would simply start secreting, right? There is another receptor setting. He'll say, okay, gland, don't secrete, stop. So it will say, okay, I'll not do that, copy that, done. Right? So these receptors, they are not doing anything. They are just like switches, on or off. And this on and off switch is getting controlled by those chemicals, right? When the chemical which is coming that, okay, switch on, so then it will turn it on. When the second chemical would come, it will say switch it off, so it will switch it off. That's how these receptors, that's why they are called as receptors. Okay. They receive the information. Now in adrenergic, there are two types, right? Alpha and beta. Alpha and beta. Let's see where are they. So gradually now we are adding more and more components into our figure. Okay. Yeah, now you should be able to see it. So in sympathetic, cell body, very well known. Preganglionic fiber, very well known. Then this is our ganglia, yes, known. And we are talking about sympathetic. So here is the acetylcholine because it is universal for all the ganglia. Yes, it is acetylcholine. All right. This is some newcomer who is coming, right? We'll come to that. Postganglionic fiber, we know this part. And then there is the end organ or tissue. Okay, so that is like a smooth muscle. So right now let's take example of smooth muscle. It could be cardiac, it could be exocrine gland, anything, but they are collectively called as the neuroeffector site. Neuroeffector site, the site where they will be working. Here we see two things which we already know. One, acetylcholine, known, and this is norepinephrine, right? That is, so we have, because this is sympathetic, So acetylcholine, and over here it is norepinephrine. Epinephrine. Right? So that is our neurotransmitter. Right now, don't worry about the epinephrine. That's something which will be coming all the way from the adrenal, and then it will come into blood, and then it will affect. Yes, it would happen. But right now, this system. Okay. So we are dealing with this. Adrenergic receptors. Adrenergic, right? That means related to adrenaline. Adrenaline means we are talking about sympathetic receptors. And in sympathetic receptors, we have alpha and beta. But then from where he came, this nicotinic, right? Nicotinic receptor, and where the N is written, well, keep it on halt. As such, you must have even guessed also that because this is a universal system, right? So that's why obviously it will act on only that receptor to whom he is sensitive, right? If I like sweets, so then I'll be tempted by sweets. And then if there is anything like, say, something which is bitter, so that won't appeal me. So over here, it is this acetylcholine. So anything related to acetylcholine, we call it cholinergic, right? That is the cholinergic. And cholinergic, so this nicotinic is nothing but cholinergic receptor, as he is sensitive to acetylcholine. So that's why we'll call it a cholinergic receptor, right? R is this way written, R is our receptor. And nicotinic, yes, that type would come, nicotinic, muscarinic, and then their subtypes, etc. But right now, this part we understood, correct? That acetylcholine is secreting, so there has to be a cholinergic receptor. Otherwise, those slots won't fit. And over here, right now, into this area where there is norepinephrine which is into picture, so there has to be a sympathetic receptor which are alpha and beta, right? So let's go into this. That's right, nicotinic receptors, they work in this exactly, because everywhere you will be requiring some receptors. On end targets, there would be muscarinic receptors. Okay, so now cholinergic receptors. Still, we have not talked about the types of alpha and beta. Gradually, we are going into the depth, right? So cholinergic receptors, they are nicotinic and muscarinic. Nicotine and muscara, they are nothing but they are the drugs, they are the chemicals. So those chemicals, right? These receptors, they are sensitive to these chemicals, so that's why such names are given. So things will go now like this, that here it is the parasympathetic, and as we said that parasympathetics, they will be having the long preganglionic fibers, and then there is our ganglia, and that ganglia, which is where the acetylcholine, right? It is for day-to-day activity. When it is for day-to-day activity, it would say that then we need to be more specific. So that's why for specificity, it will say that I need to talk with my end effector organs closely. So that's why post ganglionic fibers, they are smaller. And as it is day-to-day activity, so why to make things complex? So it will say we'll use the same neurotransmitter, and acetylcholine is used over here also. But as we said that there is nicotinic and the muscarinic receptors. This is where the nicotinic will come, and this is where the muscarinic will come into picture, right? Muscarinic, they are at the end device. Muscarinic, they are the muscles. So remember it like muscarinic are muscles. So whether it is the smooth muscle or it is the cardiac muscle, right? So finally, we are dealing with muscles. So they are muscarinic, right? And over here, this is the domain of only nerves. So nicotinic, so N for N, right? N for N and M for M, M for M, right? So that's how it works. So this is muscarinic and that one is nicotinic. No, I'm not getting what exactly are you trying to say. Can you just summarize adrenergic topic means? Uh, adrenergic topic means what? No, I'm not getting what exactly are you trying to ask. Just elaborate what exactly you want. You want, because adrenergic topic is like we are doing that only. Anyway, let me know. And hang on, because say gradually we are adding the components one after the last topic. Okay, okay, we'll do that. And it will, in fact, it will come also. That's why I have written that topic twice, right? So it will come in the form of revision also, and at that point I'll take it a bit slow, so no worries. Okay, coming back to this. Yeah, say this is peripheral nervous system. Say it's, I think that's what you asked for, but this is the entire summary, right? Entire summary. Peripheral nervous system, sympathetic, parasympathetic, and somatic, right? There was like sympathetic, in which neurotransmitters are like acetylcholine and norepinephrine, right? Preganglionic, so that is acetylcholine only. And these are the ganglions which are for sympathetic and parasympathetic. They are not for this somatic, right? So somatic means straight away the nerve would go and will say fire and it would work. So that is where it has got the acetylcholine. True? Okay. In parasympathetic, yes, we talked about this acetylcholine all the way. However, this is special. Postganglionic, it is the norepinephrine. Right? So preganglionic receptors in case of sympathetic, right? In case of sympathetic, preganglionic receptors are sympathetic receptors. Am I right? Right? In preganglionic receptors, it was the nicotinic receptor, right? You saw that, right? That an image, because it is like acetylcholine is working, no? Acetylcholine is working, so we'll require a cholinergic receptors. So that's why it is nicotinic, even into the sympathetic system. In parasympathetic, no confusions everywhere. It is the cholinergic receptors all the way. Cholinergic receptors are nicotinic and muscarinic, right? Nicotinic, where are they? They are into this preganglionic receptor, preganglionic. So just before into the ganglion that is sitting over there, right? And when it comes, so it will be working on this nicotinic receptor. What I'm trying to tell you is this part, right? It is this part. It is this part, right? Preganglionic, because it is same for everyone, whether sympathetic or parasympathetic. The change is over here, like the target. The target in case of sympathetic, that is the postganglionic, is in the form of alpha and beta. That's where things change. While over here, it is the brother of nicotinic receptor, that is the muscarinic. He'll come into picture and he'll say, okay, you take care of nerves, I'll take care of muscles. That's why name. Nicotinic is for nerves, right? And muscarinic is for muscles, all those smooth muscles. No doubt it will be handling some sweat glands, it will be handling some other secretory, but majority, right? To remember it easily, the muscles, smooth muscles and cardiac muscles. If nicotinic receptors come in, then what will happen? Well, see, that's what I was telling. That first, right? Let's understand the entire structure. Then we'll go for all those options, right? Because still we have not finished that where exactly these receptors be present, right? We are trying to construct a component. Okay. And finally, in case somatic, So they are the nicotinic receptors. Nicotinic receptors, see, in somatic, because there is neuromuscular junction, right? Now let's add something to it. This is the point where things start going bit crazy, right? Now here it is. We talked about alpha and beta. And what we did during on that end organ, right? We simply wrote alpha and beta. Right? We just wrote that, nothing more. Now see, we divided. We say that alpha has alpha 1 and alpha 2, and beta has got beta 1, beta 2. There is beta 3 also, and there are many other subdivisions, but we are not entering into this. Because some are, at times it happens that they are not present in human being, or they are in very small quantity, or they do have some questionable effects. So let's not complicate the matter. First, we only see something which is absolutely dead right, right? So here is alpha and beta. Alpha 1, alpha 2, beta 1, beta 2. Well, that's not difficult, right? That was quite easy. Alpha 1 and alpha 2. Right? This alpha 1 is excitatory and alpha 2 is inhibitory. How easy. Now this makes sense. Right? Now this makes sense because see, whether it is alpha 1 or it is alpha 2, they both are very happy in the presence of adrenaline. So that is epinephrine and norepinephrine, because they are sympathetic, because they are adrenergic. But their nature is different, right? It is like one is an attacker, and one is an arrestor, right? It's like this is our rapid action force. They go and they bombard, they fire, right? And when everything is fine, these alpha 2, they go and then they put hatkadi into the hands of those culprits and then they take away. They don't fire. They are inhibitory. They say, ke chalo, yahan se chalo, right? That's how they work. It's like they both are given command from the headquarter. Okay, go and work. So alpha 1, they say we are rapid action force, so we'll fire. Alpha 2 will say, okay, we'll wait, right? Our work is just to capture them, right? To tell them, okay, shant raho, right? So they are excitatory effect and there are inhibitory effect. So when it comes to excitatory, remember excitatory, muscles, they don't understand any language. They say current has come, contract, bas. They say current has come, action potential has come, to contract. So now wherever those muscles are, they will contract. Now, vasoconstriction. These alpha 1, they are into vessels, right? They lead to vasoconstriction. Vasoconstriction, now the vessels, they are now narrowed down. When the vessels are narrowed down, it's not so that in sympathetic system, the blood from 5.5 liter, it will increase to 6.5 liter. No, it will remain same. But now because it is needed, you need to pump up the blood pressure, right? So that's why they'll say, okay, all those choti arteries, right? All of you constrict, right? No need to give supply to all those digestive system and all other organs, right? This is an emergency. So they constrict. When they constrict, right, obviously the blood pressure would start rising. But when it comes to alpha 2 would say that yes, we are also given the command. So what will you do? Okay, our work is to stop them. Inhibitory effect. So where are they? They are into intestines, right? They are into intestines and CNS. So what would happen? They lead to vasodilatation, right? Vasodilation. That leads to vasodilation. So blood will start pooling into brain because where the need is. The beta, what will it do? It has got inhibitory effect, right? Smooth muscle relaxation, but there is beta 1 and beta 2. They'll say we have also got inhibitory effect, but this is in a different way with some exceptions. There are beta 1. Beta 1, they are present in heart only. And when beta 1 is stimulated, it has got positive chronotropic and inotropic effect. Now getting the pulse. how it is happening. From sympathetic, it came to those beta. Beta, in that also we are specific to beta 1, and beta 1 which is present only on the heart. So these beta 1 commandos, they are said that you, wherever you go, tell them to beat faster, improve their conduction, right? Improve their speed, improve their force. So they'll say, all right. And but they are present only in heart. So they'll say, okay, heart, you start beating at a faster pace. Heart, you beat with a force. So this rate is called as the chronotropic effect, and this force is called as the inotropic effect. So chronotropic, where the heart rate is increased; dromotropic, when the conduction speed is increased; inotropic, when the force of cardiac contraction is increased. Right? So things are good. So here the contraction becomes more and more powerful. Now this beta 1, the brother of beta 1 is beta 2. Now beta 2 would say, well, you are contracting, right? So you do your work. My work is different. It'll say, I'll to tell them to relax, right? Whether there is any emergency, so what? Relax, right? And they'll say, that's why we have put you into the airways, airway and blood vessels, right? That's why we have put you over there. Otherwise, if you are into heart, you will tell the heart, okay, heart, relax, no need to contract, right? Unnecessary, that person will go away. And if it becomes reverse, beta 1 is present into those airways, so they'll say, yes, come on, airway, contract, right? And then they'll fully contract. They'll not let even the oxygen pass. So this is the reason, depending upon the nature, right? Depending upon the nature, it would say that these smooth muscles and airways, right? All of you relax, and that leads to bronchodilation. Bronchodilation. So whole idea is towards one specific goal. Send good amount of oxygen into the entire body wherever it is needed, and heart will say, okay, I'll speed up the thing, and then over these lungs, they will say, we'll pick up the oxygen and we'll put it into circulation faster so that body gets it. Right? Okay. The location of these sympathetic receptors. Location of sympathetic receptors. Alpha 1, right? Alpha 1 into smooth muscles, those blood vessels, right? GI, uterus, radial muscle of eye, salivary gland, liver, suddenly from where the liver came up. Now see, it is not only the oxygen which is needed, large amount of glucose is also needed, right? Large amount of glucose is needed. So this is controlled by, this is handled by liver. Liver would say, yes, I'll supply this, right? So that's how it goes. Alpha 2, which is into pancreatic islets of Langerhans, nerve terminals, and they are of inhibitory type. One more reason why it is said that at times it is said that the stress is very bad, right? Stress leads to diabetes, and people, they laugh on us that, is it so? Is it so? It leads to diabetes, right? No, the things are like this, because in case of sympathetic trigger, it will lead to stimulation of alpha 2. This alpha 2 will go and will create an inhibitory effect of islet of Langerhans in pancreas. And these are the islets, what they secrete is insulin. And it is this lack of insulin, because obviously the body would say that right now you are worrying about lowering the glucose. I'm telling liver that, okay, you fire the glucose levels high, and pancreas, you are trying to lower it. Alpha 2, stop the pancreas. So alpha 2 will say, okay, pancreas, don't work, right? We don't need your insulin, because blood requires high amount of glucose. So it will inhibit. That's the point. If this sympathetic system is constantly firing, that means person is in constant stress. These are the reasons why it leads to hypertension, high blood pressure, and diabetes mellitus. These are the reasons. We need to understand it very clearly. I always tell, forget about others, learn this thing for yourself. Because once you know that, okay, this is what is happening, that's why this stress is so bad that it is affecting my pancreas straight away, right? So that's the thing. It is what is why this is so bad. Now this beta 1, right? Beta 1 which was present only in heart, yes, it will be acting on heart muscles. And beta 2, that is on blood vessels, GI, urinary tract, yeah, right? Urinary tract. Because when it is the point of fight, one cannot say, let me go to washroom and then come and fight with you, right? So all these things, they need to relax. They need to relax. Then and then, actually, it can be performed. And this is like beta 3. We'll talk about this beta 3 after some time. It's present in, just remember, it is present in adipose tissues, right? As it function will come. Regarding this location of parasympathetic, now we are adding one more component to it, right? And trust me, this is the last part. Right? We could have learnt it in this way, that right from the beginning, straight away, right? This cholinergic receptors and adrenergic receptors and this, that, everything. So it confuses the entire thing. Here, we know this nicotinic receptor, nicotinic receptor, and the muscarinic receptor. And we remembered it like nicotinic was for those nerves, muscarinic was for muscles. Actually, it is like that only. Actually, we divide nicotinic into N, N, and NM. Right? Now we are adding it to it. This is where that question which you asked, that what would happen that when nicotinic receptors, they come into muscles? Well, they do come, but there is a different subtype, right? So this nicotinic, okay. So this nicotinic N, it is into ganglia, it is into skeletal muscles also, right? In few cases, but as such, it is into ganglia. This is what you have to remember the most. And then NM is into neuromuscular junction. It is into neuromuscular junction. That muscarinic M1, M2, M3, three types. They are present into some of the nerve terminals or the gastric glands, right? M2 is into smooth muscles. So these are the cholinergic nerve endings, right? Obviously, because this is where it will be working. And these are the smooth muscles, which are the secretory glands, right? These are where they are present. So parasympathetic and sympathetic. Parasympathetic would decrease the blood pressure. Sympathetic would increase the blood pressure. Right? It will lead to meiosis and mydriasis. Well, it looks impressive, but I'll tell you not to forget, not to cram. So sympathetic was leading to what? Sympathetic was leading to wide open eyes. But so that is called as mydriasis, right? It is dilated when the pupils are dilated. Meiosis when they are constricted. Just imagine you watching a film with half open eyes, right? And yes, you can watch a film once you have completed your studies. There is no harm. I do watch, right? Okay. And then respiration, parasympathetic bronchoconstriction, because less oxygen is needed. Bronchodilation, yes, large amount of oxygen is needed. Done. Gland secretion. Gland secretion. Those secretions, they are for digestion. Yes, right? We are into the process of digestion while watching the movie, right? So glands, you increase the secretion, right? We are fighting, right? No digestion right now, please, right? So gland secretion decreases. Same thing, GIT, right? GIT, yes, there is increased motility, there is peristalsis, right? All the muscles, they are happily working, digesting, and now in the case of sympathetic, fight is in process, right? No one would digest anything, no one would waste any blood, no one would waste any of the oxygen, right? Remain silent and let the body fight. Urinary bladder, as discussed. Detrusor muscles, right? It is all good, comfortable, fine. So contract as the situation is good. So urine can be passed, but the sphincter is constricted. So then message goes to sphincter also, okay, relax and let the urine pass. Over here, situation is completely reverse. Urinary bladder. So detrusor muscles, you relax, right? Detrusor muscles, right? They will relax and those sphincters, they would contract, right? So urine is not passed. Uterus. Uterus, in case of say sympathetic activity, it has to relax, right? Otherwise, that stressful situation will lead to abortion, right? That baby would be spilled out. So that's why under that stress, right, it has to relax. However, in the stages of that parturition, baby delivery, right, there are, say, different stages where the contraction and relaxation of uterus will come into picture. So that is what we'll be discussing at length in the obstetrics when things will be going into complete depth, because there are various stages, how it passes from say false pelvis to true pelvis, where it takes turn, how it rotates, how the presentations they come, right? All those things. And what happens when the presentations are wrong, right? Presentation means which is the first part enters into the canal for the outside world. So when we say parasympathomimetic, you'll remember the word mime. Mime means mimic, right? Right? You must be knowing mime, right? That is also a form of acting. So then parasympathomimetic means they will be behaving like parasympathetic system. So parasympathetic system is what? Cholinergic, because of acetylcholine, right? So it is cholinergic. So cholinergic agonist. Agonist means supporting. Antagonist means reverse. Antagonist means ulta, right? It is negative, right? Agonist, yeah, and in sympathetic, how it relaxes the uterus, yeah, because of those receptors. Because say in case of stressful situation, it is not needed to contract the uterus, it is to relax the uterus. In fact, we have still not gone into the complete depth. One of the very important thing, right? Because you have asked, that's why I'm telling you. One of the very important aspect is that when the male and female, they are intimate, right? So at that point, so many changes in the body, right? In the form of male reproductive organ and the female reproductive organ. So there also, there are some of the stages of parasympathetic system and there are some of the stages of sympathetic activity. So it is a very finely tuned balanced system which goes for sympathetic and parasympathetic, and that is what leads to that what is called as the climax, right? Anyway, that would also come into the physiology as we'll discuss about it, right? But yes, it's an awesome game of sympathetic and parasympathetic activity both working together as per the stage, right? Okay, so coming to this parasympathomimetic is where the acetylcholine will come into picture. So it is called as cholinergic agonist. Agonist means supportive. Antagonist means reverse, right? So right now, let's forget antagonist, right? Not right here. Let's avoid confusion. Then cholinomimetics. This makes sense. Cholinergic mimicking, right? Muscarinic drugs or nicotinic drugs, straight away this is self-explanatory. because our receptors, they are muscarinic or nicotinic. So straight away they will go over there and will say muscarinic, yes, you work on it. Obviously they are more specific. Similarly, parasympatholytics. Lytics means they are working against it. So here there are cholinergic antagonist, right? They are inhibitor. Anticholinergics, that also means the same. Cholinergic inhibitor, cholinergic blocker, cholinolytics, they all mean the same, right? I wrote these words so that you start preparing yourself for what is about to come, right? Not immediately, but when in pharmac, these words will be used like anything, because there it is not possible to explain everything, right? So in cricket, the way it is said that, okay, this is a square cut. So when it is said it is a square cut, he'll not actually say that this was the direction of the ball, this is how the bat moved. As you know that what exactly is a square cut, even if you are just listening, it created a picture in your mind. So these words should create a picture in your mind, that when it is said that anticholinergics, immediately anticholinergics, that means they all will be working against the acetylcholine, right? So that means what? Acetylcholine, they will be working against it. That means they will not be allowing parasympathetic activity to flourish, right? They will suppress it. So that's how it goes, right? So that was for our first session of today, right? And we meet after, say 20 minutes, 25 minutes. All right. Okay. Come back, right? And we'll have some good topics in our second session. Thank you.